to welcome Dr. Jose Pagan, who is a member of the INQRI National Advisory Committee, and he will be introducing our speaker today. Thank you.
Thank you, Heather. Our Future of Nursing webinar speaker today is Dr. Marion Broome. Dr. Broome began her leadership role as University Dean of the Indiana University School of Nursing in 2004. In addition, she is a professor in the school's Department of Family Health Nursing. In April 2006, Dr. Broome was awarded the rank of Distinguished Professor by the Indiana University President. Widely regarded as an expert, scholar, and leader in pediatric nursing research and practice, Dr. Broome has been externally funded by the American Cancer Society, the NIH, as well as private foundations over the past 2 decades to conduct research in which she developed and tested interventions designed to assist children to cope with acute and chronic pain. Her recent research has extended into research ethics related to informed consent and assent for children in research and research misconduct in clinical trials. Her research is published in over 72 papers in 50 refereed nursing, medicine, and interdisciplinary journals. In 1997, Dr. Broome was appointed to a 4-year term as member of the Nursing Science Study Section at the NIH, and in 2004 she was appointed as a charter member of the new Nursing Science Study Section, Children and Families. Dr. Broome also has served as president of the Society for Pediatric Nurses, and she has been on the boards of the Association of Care of Children's Health and the Midwest Nursing Research Society, and she's serving as editor-in-chief of Nursing Outlook, and she's a fellow of the American Academy of Nursing. So, Dr. Broome, welcome to the Future of Nursing webinar series.
Thank you. Should I just start?
Yeah.
Okay, I'm sorry. I'm going to spend the next 35 minutes sharing with you some of my thoughts about doubling the number of doctorally prepared nurses. This is actually one of the recommendations, as many of you know, out of the IOM report, but it's actually one that has not received a lot of attention. Excuse me, I have a sore throat this morning, so I may kind of go in and out, but I'll try my best. The recommendation does talk about doubling the number of nurses with a doctorate. It goes on to say schools of nursing with support from public and private funders, academic administrators, and university trustees, as well as accrediting bodies, should double the number of nurses by 2020 to add to the cadre of nurse faculty and researchers with a concentrated attention to increasing diversity. What's interesting to me about this report is I haven't seen a lot of discussion about asking why we should double the number, and I personally think that's more important than the very long discussions we have had in the discipline over the last 5 years about how and what we should prepare. Whether I'm not going to touch on it all today, the discussion of the doctor of nursing practice versus the PhD, I will leave that for other people to talk about. I think it's far more important to ask why and for what purpose we're doubling, what our graduates are really prepared to do irrespective of the doctoral degree, and what innovative approaches I believe academia must take to ensure the most effective use of talented doctorally prepared nurses in the discipline. My premises for this talk is I believe that the unique role of the doctorally prepared nurse, PhD, or DNP is twofold. One, I think we must all engage and lead educational reform at all program levels. We have tended to silo ourselves into PhD programs or now DNP programs or master's or baccalaureate with, frankly, very few of the doctorally prepared faculty in our country engaging in any curricular reform discussions with our baccalaureate students when, in fact, they are our future. I also think a primary role of the doctorally prepared nurse is to co-lead patient outcomes improvement initiatives in a specific area of healthcare delivery, whatever their area of expertise is. I think our current programs of research are rather traditional and, frankly, very disconnected from healthcare delivery. My introduction didn't it was an older introduction. It didn't speak to the fact that I have just finished 4-year term on the advisory council at INR, and I think there's been some changes, not in NINR, but in the way we look at funding, and I'll be talking about that later. But I think we need to examine both of these roles, both research scientist as well as educator. I'd like to talk about the first unique role that I think doctorally prepared nurses must play in the future. We now, and why is this an issue? Frankly, 50% of the nurse educators in our country are master's prepared. And younger faculty in their 30s or 40s with doctoral degrees are insufficient to maintain the academic workforce in terms of our graduate education. And master's prepared nurse educators do not have the knowledge and skills essential to implement the full scope of the academic role and mission related to research in particular, and also the service. Much of the service that goes on in universities must, in fact, be carried on by tenure track or tenured faculty members. And for us to go forward in nursing, I think we're going to have as many doctorally prepared nurse faculty as possible. And I think I'll just share a little bit about what we have been doing and have done here at Indiana, and I would never make a claim that this is easy, politically or otherwise. But when I came, our clinical track, which is ranked, clinical, associate, and tenured and full professor, 90% of the faculty had master's degrees, and primarily we're teaching in our undergraduate program. And in 2006, I suggested strongly that people return for their doctorates, but also came up with a package to help them do that, a course release every semester for 2 years, as well as some financial assistance. And I can now say that out of the 22 positions on our clinical track, we actually have 16 people either have completed their doctorate or are currently in doctoral programs, and we're not hiring onto that track anymore. Just people who see their terminal degree as a master's. So I think there are ways to do that, but I think we need to understand that that's going to cost some resources, and time is one of those precious resources, but also some financial funding. I also think the reason it's important to have doctorally prepared faculty engaged at the undergraduate level is, frankly, the structural framework for most curricula in our country is 40 or more years old. I think in almost, I'm sure there are exceptions, but in most universities it doesn't look a lot different from the undergraduate baccalaureate program I attended, 69 to 73. And it is based on a specialty model, pediatrics, OB, et cetera. In general, there might be an evidence-based practice course, but I think we struggle to make sure that our curricula, especially from an educational standpoint, are evidence-based. And I think there's been 2 recent reports, the IOM and then Benner's work, that really talks about the critical need for reformation so that we can prepare graduates for the incredibly complex healthcare delivery system they will be working in. I also think that it's going to be critically important that faculty co-lead patient outcome improvement initiatives in a specific area of health delivery, and like for somebody like me, that would be pediatrics, and for other people it might be community health or transition models or whatever. And we have some outstanding examples of this in the discipline, but not enough, not nearly enough. And I think doctorally prepared nurses, again, irrespective of whether they have a DNP or a PhD, must co-lead these patient outcomes improvement initiatives. They must mobilize their knowledge, their analytic abilities, and expertise in leading teams. We have significant gaps in what we know about patients, what nurses do with patients, what's effective, how we monitor the health of at-risk and high-risk individuals and their families. And frankly, I would argue that nurses are the group of health professionals that really have, for years, had this knowledge. The nursing intervention models that have been tested through funding at NIH, and again, all the funding that went into transitional care models, but many of the other areas in pain management, symptom management, et cetera, can really be brought to bear on these problems. But we don't have nearly enough doctorally prepared nurse researchers, patient outcomes researchers, faculty leading evidence-based practice initiatives in hospitals right now to be able to really make an impact in this area. And I think one of the reasons we don't have enough, and I'm well aware this is going to be a little controversial, is I think that we have great walls between teaching, research, and practice that are killing the discipline's promise and potential. I think we could ask ourselves, why are there so few doctorally prepared nurses available to teach? These are a lot of the things that you hear. PhD education is too costly. In fact, in most places, it's not a lot more costly than a baccalaureate program, and yet, as we all know, we have more applications and qualified applicants, outstanding applicants, than we can handle for those baccalaureate positions that we have available in our schools. And so I'm not so sure it's all about the money. You'll also hear that PhD education takes too long. I think there have been models. One that comes to mind is the Betty Moore Foundation, who funded PhD students for full-time for 3 years, and I believe it was UCSF and UCLA who worked with the Betty Moore Foundation to get those students in and out. And I think that all doctoral programs have to be thinking about that, getting students in and out, maintaining quality, but finding financial packages, finding, frankly, faculty workload models that will enable students to get in and get out. I don't think the tenure gold ring is really, for many of the young faculty, they do not see the 6 years of extreme pressure, especially the younger faculty now, as being as valuable as it once was. Of course, all disciplines, only 25% of educators now, not just nursing but everywhere, are actually tenured. So tenure is becoming much less prevalent, and I think the role models are also much less prevalent. There is some discussion whether this is a myth or not. A DNP is not valued for tenure track appointments. Actually, there was an article I just recently found in Journal of Professional Nursing that did a survey, national survey. I think the response rate was a little bit over 30%. And in fact, two-thirds of the universities that or participants from the universities they surveyed said that they would consider a DNP for their tenure track. I think a lot of people are thinking that it depends on the person. I know it here at Indiana. We've actually offered PhDs appointments to the clinical track because they don't have the same type of track record or they don't have the same type of research program or focus that our tenure track assistant professors have. They are incredible academic citizens and do have programs of scholarship, but they didn't see themselves, nor did we, on the tenure track. That's not, I think we need to see, the discipline needs to see this, at least dialogue about it. And I always personally find it amusing that nobody thinks twice about MDs being on the tenure track, but that's not here nor there. Salaries are not competitive with industry, and that is very true, and we're going to have to address that. The average assistant professor, even in a senior AACN salaries for assistant professors, doctoral granting, Midwest in public institutions, the mean is 68, the 75th percentile is 74. That is not competitive with practice, where they'll be coming in at 80 to 90,000, depending on the particular job with a doctorate. Here's the one that I think is really important. Doctorally prepared educators don't teach or share their excitement or passion with undergraduate students in most schools. And students may not go right on for a PhD, but if they have never had the excitement or passion that many of us do hold for teaching and for doing research and for being an academic, if they never hear us talk about that, why in the world would they ever think they want to do something like that? And I think we really have to examine what we're doing and who we're doing it with and how we're exciting or not exciting, not even exposing our undergraduate students to that. Our research programs, not all of them, but many of them are just, they're outstanding research programs and models of knowledge development, but for some graduate students, they're just not relevant to what they want to do with their careers or the kinds of interactions they want with their patients. They just don't see the connection. And I think that translates into, again, them never seeing themselves as being like us. Now, what are some of the opportunities? There are over 300 DNP and PhD programs in the U.S. And on the AACN site, what I saw, so I'm taking this directly from that, in 2011, there were 9,000 DNP students with 1,600 graduates and 5,000 PhD students. They didn't, or at least I couldn't read how many graduates there were from PhD programs. But that is an opportunity. I would certainly hope we don't have more than 300. Well, that's probably too many in my opinion anyway, because I don't think we have the programs, even in terms of the DNP, I don't think we have the faculty who have programs of scholarship and that can sustain that, but that's just my own personal opinion. I've spoken to salaries are too low but can be addressed with base inequity adjustments, and that there was an interesting article this month in the Chronicle of Higher Education, March 12th, and it actually looked at, it ranked, I believe, 26, 28 different academic disciplines, everything from anthropology to engineering, and health professions, and they were taking out medicine, were actually fifth from the top, exceeded by engineering, business, law, architecture, and I can't remember the last one. But there were 18 to 20 that were below us in health professions and salaries. So I'm not saying they're not low relative to industry, but in terms of relative to the academic or the university setting, they're not, they're in the top quartile. So I think we just have to look at the data and kind of be clear about what we're talking about. Again, in Nichols' article, 2/3 of universities surveyed said that the scholarship track record would be what the criteria that was used to determine eligibility for tenure track. I think, frankly, that has a lot of that should be very informative for DNP programs in terms of what students need to be doing relative to scholarship. Practice academics partnerships in many, many settings offer excitement and diversity that many young faculty desire. I think young faculty are now in today's young faculty do see themselves as making that connection with health systems. I think some of them are more open to these dual scholar roles, et cetera. So I think there are some opportunities, but we have to be able to change some very traditional existing systems and frankly, perspectives to be able to do that. I talked earlier about the life cycle approach to our undergraduate programs, which are setting-specific, acute care, primary care. We all know that this is not the real world, that children don't live without adults in their household. Even the most chronically ill are also, in need of health promotion strategies, et cetera. Patients spend very little time in the acute care setting and much more in the home setting dealing with their illnesses. And young nurses in practice are expected to be very cognizant about nurse-sensitive indicators and base their practice in evidence. And all of our curriculums need to reflect that. So we must, to do that, we must have doctorally prepared faculty teaching our undergraduates at some point in time. So I think we really do need a reform of our education models, but starting with the curriculum is probably not the place to start. I think we have to start with the faculty and to expect 50% of our educators to have a grasp of data management, data analysis, system trends, interventions designed to change practice, whether it's in the community or in acute care institutions. That is all those skills are all inherent in doctoral education. And I think if we had any mandate, like in doubling the doctorates is an interesting way to phrase that if you think about it. We didn't say 80% of educators should have their doctorate by 2020. We said double the number of doctorates. I'm not sure that that's even going to get us where we need to be. But I thought that was an interesting way to approach that. The whole focus, and about 80 of our schools of, well, I shouldn't say 80. There are about 100 academic medical centers. So actually probably about 80 of those do have schools of nursing, and they can't carry the brunt of the research mission anymore by themselves. And this whole focus on transitional science, again, that has the skills to engage in knowledge exchange, synthesis for application, and inquiry. Those are all doctoral program competencies. Designing and interpreting dissemination research. All of these are this translational science models are going to require advanced education. However, I would also Mitchell, in this very good article that is cited here in Nursing Outlook a couple of years ago, talked about the transfer of research, and I would also argue the generation of research can be affected by a number of historic, political, economic, scientific, and I think most important cultural and organization factors. So until nursing leaders themselves set forth some clear expectations for their faculty and provide the resources that will enable the very relatively small number of faculty there are in the discipline to become as highly educated as they can, I think we are going to, we're not ever going to have enough to do the kind of work that we need to do. And most importantly, to attract these younger, energetic, and bright faculty, there has to be a sea change in the academy. And I think that's where the work, when you talk with, I teach undergraduate honor students at Indiana, and they just do not see themselves, even working one-to-one with a funded researcher, as an independent researcher. And one of the things they talk about is the length of time, post-PhD, that it will take them to be like that person. And again, I think when all of us did this, many of us did this in our careers, you don't, first of all, in general, it didn't take that long. Then it's become much more complicated and a complex issue. But I do think this protracted time actually deters many nurses from even being attracted to research. They don't see our research programs oftentimes, with some clear exceptions, as really being involved in solving patient problems. And they just do not see themselves as taking 10 years out of their life and devoting it to a program of research that may or may not be successful, that may or may not result in any impact or making a difference that they could see at that point in time. And if they can't see it at that point in time, they're not going to be attracted to come back into doctoral study, but particularly PhD. And then we have the whole issue of what about our current curricular models in doctoral education? Are they really getting us where we need to be in terms of team science, secondary data analysis? This is informatics, new measurement models, implementation science. These are changes that have to occur, and these are broader than just our pretty singular focus now on different methods of doing research as opposed to these more process-oriented kinds of topics, but topics that are critical to really making system-level change. And part of the issue, as in all curricular reform, is if the faculty if a critical mass of faculty have not evolved in terms of lifelong learning about their craft and learned some new measurement models and really engaged in team science and what does that mean and implementation science, et cetera, it's going to be very difficult to change those curricula that would then in turn attract the younger students. Not to sound discouraging, because I believe that nurses, as I said earlier, are in the unique position of really already having much of the knowledge and skills that we would need. We just don't have it in the numbers that we need. But I think we bring expertise and innovative educational approaches. I think we bring patient management knowledge, expertise to make a difference, to really make change at the system level. We are probably one of the few disciplines that brings theoretical expertise and understanding, have theoretical foundations, have to guide our interventions. I think we may be the only discipline that does that as clearly as we do. We bring, all of the arguments we've engaged in over the last 20 years about qualitative, quantitative paradigms, I think has, probably now, because we aren't steeped in just one or the other, we were engaging in mixed methods. If you look back the last 10 years, far sooner than anyone else. We do have statistical and analytic expertise that stems from a core critical mass of nurse researchers in the discipline. And I think when we are looking at joining or co-leading, teams in healthcare to change patient outcomes, we as nurses have a political awareness, or we have the collaborations with other disciplines that will enable us to gain entry. And that cannot be said. This collection of talents or experience or knowledge just doesn't exist in every other discipline or many other disciplines. But I do worry a bit again about, is the doubling enough, and perhaps why we didn't just make a stronger statement. Although, I shouldn't say that because I wasn't on the committee, and I know the committee based everything, all the recommendations on evidence, and perhaps that's the reason. But even if we do double, will it be enough? If those nurses who are prepared, for instance, as a DNP, are prepared as a DNP or PhD, and they're not prepared to teach, what I see for the younger, new assistant professors who actually come out oftentimes BSN to PhD programs, and if their programs are not carefully managed, they not only come out not prepared to teach. We know they have come out and need to be mentored in research. We've known that for a long time and have developed actually pretty sophisticated models of mentoring in that area. But they also haven't practiced. So they are, and they are very aware of these areas that they don't have experience in. And I would argue that as a discipline, we have developed some pretty, as I said, very nice models of mentoring related to research, but I do not think we've done that related to teaching or to practice. So I think deans in particular have to think about what kind of resources am I going to put behind these new faculty and assure them that they will have those resources, or am I just going to throw them all in together and say whoever, thinks and whoever doesn't. I think we have to give some careful attention to that area. And I also think, again, we need to create academic appointments, and I'm not talking about your traditional joint appointment here. We call them dual appointments at Indiana, and we're just starting out with these. I think some private schools have many more of these. Actually, I believe Penn is probably one of them. That provides immersion and responsibility in some area in healthcare that actually facilitates the transfer of research and evidence across those settings. And I think that has to be continued. Those models actually need to get a lot more prevalent. And I don't think the doubling is going to be enough if we don't address the salary differential, but I do think we have to base our salary in evidence. We need to look at how we compare to other academic disciplines, how we compare to, apples and apples. When you're comparing with industry, you can't compare a 10-month salary to a 12-month salary, and oftentimes I think that's what we do. I'd like us to talk more about doubling the number of leaders because that's what we need. Frankly, we don't need just someone with a doctoral degree. If they can't be a leader and a mentor within a very short period of time, there's nobody else that's going to do it. So I think we need to focus on the why, not the what, not the particular degree path. The variable path could be good. However, a lack of quality in either of those paths, the DNP or the PhD, in terms of preparation, will not be good. That we will have quantity and certainly not individuals with the kinds of skills they need to lead the discipline. So I think we need to give some attention to this development of leaders, and we do have some incredible programs, the Robert Wood Johnson Leadership, the Nurse Executive Program, but they're not nearly enough to be able to, especially on more regional levels, perhaps, building cohorts of leaders across states or across regions that can actually make an impact because they are a cohort, because they do have these networks. I'm just going to spend a little bit of time on this in terms of, this is sort of an older article that I found, but I think McBride also talked a lot about this in her recent book on the growth and development of young leaders in nursing. And these are just some characteristics that I think we need to give concerted attention to. How do we focus on scholarship and early scholarship in doctoral study? It should not be the end of the program. Scholarship should not ever be just what you get out of your dissertation. How do we help people to simultaneously take on different roles so they can, when they are in the university and or boundary spanners between the university and practice, how are they able to manage that kind of those competing priorities, et cetera? All that's about leadership, in my opinion. And these I will allow you to read instead of me doing that. I also have a strong belief that it is just as much the responsibility of the organization to develop leaders as it is individuals. Those are two very different sets of responsibilities. And one particular thing that I know has been I think needs to be reexamined is this protected time model, because there's ever since we've been developing research programs, there's been a notion that we have to protect very large percents of individuals' time to get them to be an independent researcher. So I don't know how much longer we can afford that. If it takes 5-6 years post-doctoral preparation to become an independent researcher, it is with 50 to 75% time bought out. I'm not sure how long that is. I don't know how much longer that's an affordable model. But I also think there's some interesting evidence that comes from business that shows when people aren't connected in networks and don't have specific goals and specific responsibilities that cross the system or cross settings, they really aren't as productive because they're more isolated when they're their time is protected. It's just some thoughts. I don't have any real answers for that, but I do think it's something that we need to give some thought to. Boundary spanners are, again, leaders. I think the future is going to be in boundary spanning from academe to practice. We don't have enough of us to not focus as well on what are you going to teach, not just what are you going to do research about, and how do those two integrate in such a way that the person doesn't feel totally overwhelmed. It's these kinds of attention to detail for the new doctorally prepared faculty that we must take time to do, or we won't attract anybody else, because they will look so stressed and so overworked that their students will look at them and say, I don't think I want to get a doctoral degree. I don't think I'm up for that. And I don't think we give as much thought to that as we possibly could, is how our presence with students at all levels, baccalaureate, master's, doctoral, really influence how they think about where they want to work after they graduate. So in summary, I know we want to leave time for questions. I think there's some huge challenges, but I am convinced that we have enough talent in this profession to address these. There is a large knowledge skill gap, especially related to research and evidence and scholarship that is currently in the nursing academy workforce. And I think this is not about whether we value people with master's degrees. That is not the question at all. It's what skills do they bring, and do they use in the academy to be able to lead, again, this educational reform and these patient outcomes initiatives. Just doubling our doctorates will only get us halfway there. I think we have to have at the national level, have some crucial conversations about the traditions that are so important to us, and that we tend to think that everybody who's coming in now needs to do it the same way I did it 30 years ago or 35 years ago. I think we have to think about how academics work, how efficient are they, how cost-effective, how accountable, and then we need to give voice. I would argue as a dean, they are very cost-effective, very efficient, and very accountable, but we don't share that and get other younger individuals excited about what we do. We just need to do a better job of that. Because if nurses in the academy, who have the most exposure of anybody to new nurses, while they're students in our programs, either our baccalaureate or master's, if we don't use our informal persuasion to recruit others, and I would guess that most people listening to this, if you have an advanced degree of any sort, you would have not gone back if somebody hadn't looked at you and said, you need to go back to graduate study. Almost everybody I ever ask about that says, yeah, that's actually true. And then they can tell me exactly the person who said that in their career. So it's time we all picked out 10 people each year to tap on the shoulder, each of our students, and say, you need to go get a doctorate. You really could make so many contributions, or baccalaureate students. You need to really think about this. So I think that would get us close to the doubling, maybe even surpass that, which would be wonderful. Okay, I think we can open it to questions.
Dr. Broome, you mentioned active professional networks. How can nurses improve their interdisciplinary networking skills? With team-based care being heavily emphasized, this is a vital component to nursing education.
Absolutely. Well, I can tell you, it's always easiest to tell either in personal stories or to tell you the story, of course, of my school, because that's the one I'm most familiar with. But over the past 3 or 4 years, we have, and many other schools do this just isn't us, this is nothing original, but many of the hospitals have reached out, and we have responded by having faculty work with their research-based evidence councils, their evidence-based councils and their research councils. We also have faculty who are holding leadership forums once a month where they're like journal clubs for all the nurse managers. We probably have about 10 or 12 faculty who are in those positions. We do compensate the faculty a little bit for that. It is extra work, there's no question about it. But the unintended positive consequences have been pretty dramatic at so many different levels. I think one of the interesting levels is that the ones who work with the evidence-based councils in hospitals have noted that associate degree nurses or diploma nurses who are on those councils, after the faculty members working with the council for a year or two start coming up and asking them about returning for their baccalaureate and what's the best thing to do, or should the baccalaureate prepared nurses start talking about graduate study. It's sort of that connection. isn't it like everything else? It's the relationship. It's all in the relationship. And I think getting into those, that's one way to get into those systems. The way, and I'll be very controversial here, the way I think that practice doesn't want us involved is being staff nurses on the weekend. They see master's prepared faculty as having skills and competencies they don't have. And they have a lot of nurses at the bedside who are very incredibly skilled and knowledgeable about patient care, but what they don't have are, and sometimes in sufficient numbers or in any numbers, sometimes in smaller hospitals, nurses who really understand research and evidence and can help to make changes in patient care and think about how do you measure those, et cetera. So I think if we listen to our partners, those opportunities they're numerous. Now, of course, then there's always in academic medical centers, I know our faculty are serving on the School of Medicine and the School of Rehab Sciences and the School of Dentistry grants, and they're on hours, and all the deans, at least in our system, really highly encourage that, and it has paid off again after 10, 15 years in incredible ways. Because in a research team, everybody's committed to that particular patient population or that particular phenomenon, and you're able to make relationships again that are pretty amazing. I hope that answers that question.
Thank you. How can doctorally prepared faculty assist younger scholars in taking primary roles in the development of ACOs?
Okay, say that one more time.
I'm sorry. How can doctorally prepared faculty assist younger scholars in taking primary roles in the development of accountable care organizations?
Okay, I will come back to what my answer previously was. I guess first of all, I think a lot of nurses don't understand accountable care organizations. And so I think doing more to educate our faculty as well as nurses in practice about what that term means. It has tremendous implications, as most of you know, for the work, for reimbursement particularly, but also it has a major, I think, opportunity for improving the health care, the patient outcomes, as I've been talking about this entire hour. I think experienced scholars who know how to lead teams, who have experience in transitional models, who focus on a population and improving health outcomes, let's say for adolescents with diabetes, and involve the family, they need to take that young scholar with them. They need to model some of that. They need to take them to the research teams discussions. They need to, if they're doing evidence-based practice council and they're helping to co-lead that, they need to bring them with them. But then again, debriefing afterwards. What did you see here? What do you think? Where's a place that you can play a role? What specific areas of knowledge do you have add to this and to make a difference?
Great. Let's see. How does healthcare reform impact the way in which we attract nurses to pursue doctoral degrees, perhaps by motivating nurses that the boundaries of the field are being redefined and it's an exciting time to study the role of nurses in reform?
Yeah, of course. Again, I think it's, let me just read that again. I'm not really sure we understand what, any of us really, what the final healthcare reform is going to look like. But I do think that we all see very subtle and sometimes not so subtle signs that nurses are taking on are going to be taking on a phenomenal role in, and I guess right now I'm talking particularly around advanced practice nurses. Just the recent set of RFAs that have come out looking to expand APN numbers, and what will that mean? And what does is the expectation, I've said this in public, so I'll say it right here, if the expectation is that every APN is going to have a doctoral degree, I can tell you as a dean that that's going to slow down our pipeline pretty dramatically, number one. And number two, to keep the quality of our DNP program up in terms of scholarship and evidence and informatics and all those skills I've talked about, it's not possible to have the sheer numbers of APNs coming through the program. I'm not saying some schools don't do that. I'm just saying for our particular setting, an academic medical center where the focus is on having doctorally prepared nurses who, again, are expected to make change in systems and not only just is not a good word, but and deliver individual care, but rather be systems level change agents. That's a different set of skills, I would argue. So I think we have to tread pretty carefully on this, and because we're going to very shortly, if not right now, running into issues of quantity and the demand for the number of advanced practice nurses, and if we're going to continue to mandate that every one of those advanced practice nurses has a doctoral degree, that I'm not sure we can meet both of those mandates. So we'll have to see how it kind of rolls out, and each school will probably make their own decision about what's the best thing for their particular situation. But, the enthusiasm isn't hooked to healthcare reform. I tell students you are in the best possible profession you could have chosen, and you can do things with a doctoral degree in nursing. The number of things you can do are boundless because of the skills that you have, all of which are centered around improving the patient's experience, whether you're an NIH-funded researcher or you're a teacher or you're, working with nurses in practice. They're all supposed to be about changing patients' experiences.
Very good. What about nursing scientists working in magnet hospitals? It seems that these people are doing clinically based research about patient outcomes, and it would also seem that these scientists have a very good grasp of what abilities stakeholders desire in registered nurses. How are these scientists integrated into the discussion about undergraduate nursing education?
Excellent question. And I can, I think we've got some new models coming out that will provide us with even more information about that. The Hinman Foundation just funded 2 schools in the discipline in the country, and I only know one. That's why I don't want to name them because I can't remember who the other one is. But they're both that is aimed at getting students through the accelerated nursing undergraduate program into doctoral study and doing it in a time-efficient fashion, but still maintaining quality. And I think we're going to learn a lot from those schools and their experience. And I'm real excited about figuring that out because the nurse scientists will be involved actually with those students. Here we have our honors students. We have usually about 10 in each of our particular class cohorts that work individually with those funded researchers. And I can tell you from having my own cohort of students that I coordinate, I'm not working one-to-one with them, they're working with the funded researchers, there is nothing in their undergraduate education that has impacted them more than that relationship with that PhD nurse scientist. Nothing. I watch them grow over 2 years, and I can just watch the transformation and look at how they're a little different from their classmates in terms of the view of the world of nursing and what they see the role of nurses at all levels to be. So I would like to see more and more of them. I think from the nurse scientist's perspective, just like all the rest of us, people are very, very busy. They're very concerned about getting their next grant out. So and getting the current one implemented, et cetera, and getting their publications and doing grant reviews and all that kind of thing. But what I have found, and I have one example that I think will be a really good example, if you dovetail someone's research program with what you're asking of them in terms of involving them in practice, it works. Because they don't have to learn new skills. They don't have to learn a new knowledge base. And they are seen as experts in that area. And I think a really good movement or initiative that came out of NIH 2 years ago, I believe, was out of the National Cancer Institute, and they asked schools of nursing to send a faculty member who had some genetics expertise to NCI to be trained, to come back and integrate that into the undergraduate program. And we had a young assistant professor who did a postdoc in some behavioral oncology, but she had been to the Genetics Institute at NIH, and she seemed like the perfect person to do that. And the reason I thought she was perfect is her future funding would be at NCI. This was a good opportunity for her to meet with program staff and be up at NCI and understand how that institute works. But she also is highly respected on our faculty in terms of her expertise, and she got a team of undergraduate faculty together to develop these genetics modules and integrate it into the program. That, I'm not saying that wasn't a lot of work by any means, but it gave her an opportunity to get something out of that experience that she wouldn't have normally had access to use her expertise to interact with undergraduate faculty in a way that she wouldn't have had the opportunity to otherwise. I think you just have to, kind of look at the holistic picture when you're working with nurse scientists and figuring out where they can make the most impact, get the most out of it themselves.
That's great. We actually had 2 questions come in at the exact same time to discuss what types of things we could do to increase the number of minority nurses interested in getting a doctorate.
Oh, excellent question. I think it's pretty similar to what I said earlier about tapping somebody on the shoulder. We currently have a T32, and we've had it for a long time. But 4 of our pre-docs are African American, and that didn't just happen. We had an incredible faculty member who, she's retired now, but she developed a program called Career Connections, and that was targeted at all of the minority students coming together and during their undergraduate program, and also some of the master's students, but coming together and hearing from senior faculty from minority populations and talking about what their career was like, when they decided to go back and get a doctorate, why they decided to do that, what have they gotten out of it. But it was, again, tap you on the shoulder. Every one of those students had to be personally invited. And not just that, kind of encouraged, to say, this is something you would be really great at. And over a period of 3 years or so, that really did pay off. And we've now noted that one of our areas of recruitment that we really need to focus on is men, and it would be the same. I believe it would be the same trajectory. You need to have men leaders in nursing come and talk to a group of young men in nursing to say, this is when I decided to go back and get my doctorate. This is why I decided. This is what my career path has been. I think when I decided to go back to get my PhD, I was 30 years old. Honestly, if you'd asked me what a doctoral degree was then, I'm not sure I could have, I know for a fact I couldn't have articulated it. But what I did know is my mentor, my dean at the time, Mary Conway, said, you need to go do this. You are one of those people that needs to go do that. And I just remember thinking to myself, I don't know what she sees in me, but she's pretty smart, so I guess I'll take a look at it. I don't think I'm very different from anybody else. And so each of us, again, if we tapped 10 students, master's, baccalaureate, minority, the problem is you have to have a relationship with students to be able to tap them on the shoulder and say, you got to come. And I think that's where the disconnect is between doctorally prepared faculty and our students, and just having that relationship already existing and then encouraging them to come. For minority students, it's going to take the personal connection, and it's going to take modeling by senior minority faculty, doctorally prepared faculty, to be able to encourage them as well.
In thinking, this is just a recommendation, in thinking about the networking, there's a suggestion that groups like Sigma Theta Tau, ANA, and other groups could serve as a mechanism for some of the networking, and using social media and email, which is an idea.
Mm-hmm. Absolutely. Oh, yeah, that's another. Now, don't ask me anything about that because I really don't know much about that. But that's this new generation, and we have to figure that out. We have to figure out how to connect better. And the one thing I do know about this new generation is that that social connection, that relationship, is so very important. It's more important than probably to any other generation to date. So, yeah, we have to think of all new ways. But, it's the level of enthusiasm. If you don't like your job, you won't encourage anybody else to take your job.
Okay. Well, thank you all so much for joining us today. This has been not only a wonderful presentation, Dr. Broome, and we thank you for that, but it's also been just a fantastic discussion. These are wonderful questions and really get at some of the challenges and opportunities. So I thank you for being part of this session, all of you.